Thank you very much. I appreciate this invitation. My name is Peggy Kelley. I'm a pediatric otolaryngologist in Portland, Oregon, and today I'm going to be presenting with my co-presenter.
Hi, I'm Shanna Harris. I'm a pediatric nurse practitioner and a lactation consultant.
Great. Today, we would like to present to you, and we can advance the slide. And we want you to know that we have no relevant financial relationships with the manufacturers of any commercial products or providers of any commercial services discussed in this activity, CME activity, and we do not intend to discuss any unimproved or investigative use of a commercial product or device in this presentation. Today, we are going to hope that at the conclusion of the presentation, you'll be able to describe the current level of evidence to support surgical intervention for ankyloglossia and other tethered oral tissues, to identify a differential diagnosis for breastfeeding concerns that may mimic ankyloglossia, but should be managed non-surgically, and to summarize at least one area of debate and need for research in ankyloglossia and other tethered oral tissues. I want to mention that a lot of these slides were from the co-presentation that Shanna and I did at the American Academy of Pediatrics meeting. And so there they talk about changes in practice. And so the changes that we thought that some of the people listening might be wanting to make were to reflect on how they are managing tongue tie and who they're referring their babies that they have the concern for tongue tie to make sure that the multidisciplinary team was emphasized and to consider learning if they wanted to learn how to do a frenulotomy themselves. So this is a typical problem for us. So my fourth patient of the day walked in. Well, parents brought them in. It was a 17-day-old newborn who had been gaining weight, but mom noted that the little one had painful breastfeeding. And the primary had sent them over because the PCP had noted a tongue tie, and mom could see a heart-shaped tongue tip. This was a big baby born at 41 weeks, 1-day gestation, and was weighed at birth 3.95 kilos, and today, only less than 3 weeks later, was up to 4.3 kilos. So they had seen the lactation specialist in their hospital, but they had not had any lactation services follow-up. And the primary had said, come see PCP, had said to come see ENT first. Mom notes that breastfeeding is very painful, and so she's pumping during the day, and the baby is taking 4 ounces at a time. She puts him to breast for dream feeds and thinks it can maybe take an hour to finish that. So is this baby having a problem? When I talk with families in the clinic, I ask them what they think tongue-tied is. Some say, oh, I thought it was just a figure of speech. Some wonder if it could cause speech delay in the future or be the cause of breastfeeding trouble. Dentists are often concerned about the increase in dental cavities, and I have certainly seen older kids who had difficulty with debate team voicings and triple tonguing their instruments, and some kids just can't stick their tongue out to lick things. So it could have the ice cream going up their nose. So why do we even have a webinar on this? Why does it even matter? It matters because there's been a significant increase in the number of babies diagnosed as tongue-tied in the US and internationally in just the last 10 years, and that there is a significant increase in the number of frenotomies that are being done. So there is a concern that ankyloglossia may be being overdiagnosed. What does overdiagnosed means? That the patient may have no benefit from the diagnosis and may even be harmed because of the treatment of the diagnosis. So Shanna is going to talk a little bit in the next slide, but this is from a paper that's back from Walsh up through 2015, and you can see that lingual frenulectomy was increasing from 1997 to 2014 on a linear basis, but then exponentially it took off in about 2010. And so now it is growing at a horrible fashion.
So this slide is the Google Trends slide for the past over 12 years, and it really kind of extends out what that last slide was just showing, but you can see how Googling ankylglossia or tongue tie really picked up after 2016 and has just grown, and now is going off of the chart.
And you could see on that last slide, there were a couple of dark spots. So you can see that even in places across the country, it varies. So why does this whole tongue tie thing matter? It matters because breastfeeding is super important. And it's recommended by the American Academy of Pediatrics for moms to breastfeed for a minimum of 6 months with the goal of continuing for up to 5 years. And so we all want to be sure that the assessment of a mother-baby dyad with breastfeeding issues have their best chance at meeting the recommendation of breastfeeding and breastfeeding long-term. So I think it's interesting to look back in history. So remember that breastfeeding was primary until about the 1890s. It's said that a midwife would keep a long fingernail just so she could slice that frenulum at birth. And then came the 1900s, where there was a specialization of medical providers. Now, that happened so that instead of just one kind of doctor, now you had an OB doctor and you had a family doctor. And that was the same time that the development of better and more hygienic ways of feeding babies became available because formula was developed. And interestingly, the whole entire shape of women's bodies was expected to change. And so if you look at the pictures from the 20s versus the pictures from the 50s, you see the breasts are now perky. They're no longer allowed to be pendulous. And it wasn't until the 1970s that it was determined that breast milk was actually better than that hygienic formula. And so there was also at that time a return to natural as women's rights were increasingly recognized and they weren't necessarily forced as much into one type of a look. It has gotten to the point that now in the history as we look back, if a mother cannot directly breastfeed, she's considered deficient. But really, is breastfeeding possible for every single person? And more importantly for this talk, is it always the baby's fault? So I think that I've come to think about breastfeeding and tongue tie in a different way. We know that only 50% of babies with a tongue tie have problems with breastfeeding. So that must mean that there are universal breasts that are perfect for breastfeeding. So that a baby with any tongue type, tongue tie, not tongue tied, they can breastfeed. Now, I've come to this conclusion because I see older kids in my office for other problems, sleep apnea, etc. And I'll see they have a very severe anterior tongue tie. And I'll say, hey, were you able to breastfeed this child? And the mom will go, oh, yeah, it was no problem. Breastfed for 2 years. I'm like, okay. And then I think that on the other side, there are some babies whose mouth shape, tongue protrusion, skull base, palate, all of those things are perfect for breastfeeding off of any type of breast or nipple. Some babies don't care if formula is coming from a slow flow, fast flow, whatever shape there is. It can be, that's why there's so many variable ones, but some babies will take it from anything. So there must be universal mouths as well. And where we come into the conundrum of today is that there's no guaranteed match. The baby that I may grow within me and birth may not be a match for my breasts. I may not be able to breastfeed my own baby. So what is important? It's important that if there is a restriction or a tie that could be released without significant harm to the baby or to that mother-baby dyad, that we identify it and take care of it. We definitely want to avoid any oral aversions from tongue stretches that are required after laser release. We want to avoid pain from having multiple raw areas in the mouth because these things can lead to oral aversions as well. And then there's always a goal of avoiding exposure to anesthesia. So I think it's important that when we talk about tongue tie, we're all talking about the same thing. So let's start with some definitions. What is a frenula? It's a fold. It's a membranous fold that attaches one anatomic structure to another. So a frenula is not abnormal. In the mouth, we have lingual frenula, maxillary frenula, labial frenula, mandibular labial frenula, and buccal frenula. So a tight frenula restricts movement or function. So a constricted lingual frenulum affects the ability of the tongue to move as intended, which is a tight tongue, could be called ankyloglossia, also known as tongue tie. So what is a frenotomy? A frenotomy or frenulotomy is a division of that band, that frenulum. A frenulectomy would be an excision of the frenulum, and a frenuloplasty is to change the shape of the frenulum involving stitches and may or may not have flaps. In addition, there's no such thing as a revision if you haven't done something to the baby first. So in this slide, you can see two newborn tongues. The picture on the left shows a tongue that's easily able to elevate. You don't even actually see that membranous fold coming down into the floor of the mouth, but in the baby on the right, you can see that band that is preventing the center of the tongue from elevating anywhere near the roof of the mouth. So let's talk now a little bit more about some anatomy terms. So the dorsal tongue is the top of the tongue. The ventral tongue is the area under the surface of the tongue. And the floor of the mouth is the space between the inside of the mandible, the jaw, and the ventral tongue attachment. So the posterior tongue is actually way back behind the foramen cecum. So go along the top of the tongue, slide over the top of the tongue, go into the back. That's the posterior tongue. And the tongue base is where that posterior tongue meets the epiglottis. So has this been looked at recently? Turns out that Mills is an anatomist who did some work in 2019. So our knowledge isn't based on just the past, but also recent. And she found that a frenulum is not a discrete band of connective tissue. It's actually the fold when you elevate your tongue. It's going to be, it becomes more evident. And there's this fascial sling under the mucosa that attaches to that ventral tongue that forms with elevation. So they have this basket weave orientation as they cross the midline, and she found that was consistent with past gross anatomy of 1966 histology. And she noted that where it starts and stops varies, as well as how thick it is varies. It may be just mucosa, it may be mucosa with the fascia, or maybe even include the genioglossus muscle. So let's return back to now our anatomy terminology. So the lingual frenulum is in the floor of the mouth. So it's just under the tongue, and it does not insert into the tongue base. Remember, that's back over the top of the tongue, back by the epiglottis, but inserts just inside the jaw. So when people are talking about an anterior tie and then move into, well, there's no anterior tie, it's a posterior tie. Posterior tie is a very unfortunate term because it's just not anatomically correct. And so what we really are needing is some kind of a term that means when there is poor function of the tongue and no visible band to release. Because everybody, as you see in the picture on the right, when you pick up, you're going to see all of the pieces of the floor of the mouth, whether or not you see the actual mucosal band of the frenulum as the tongue elevates. So Mills came up with this model. She said before, in number one, it was presumed that the lingual frenulum was this discrete green structure, that submucosal band, that green thing that's underneath. So you'd had to divide through the mucosa and then snip that band. But her evidence was more based on the understanding of that whole lingual frenulum structure. And so she said, actually, there's the mucosa and then there's a fascial layer, and that in some cases, the frenulum may be only mucosa, which is seen in B, or it may be mucosa plus fascia, which is seen in C, or it may actually also involve the muscle, which is what you see in part D. So her deeper dissection didn't find that there was any persistent band that was going down between the genioglossus muscles, which called into question, what the role of the deep frenotomy was. She also found that there were nerve fibers for sensation and motor movement very near the surface of the ventral tongue. That's the underneath portion of the tongue where the divisions are done for frenulotomies. And so for her, that called into question the broad diamond, particularly done with thermal energy, that the damage that could cause as you go laterally. And pointed out that the lingual fascia has two balancing roles. It provides the tongue stability and facilitates tongue mobility. I hadn't thought about this before, but she pointed out that the tongue is suspended and it moves without a skeleton to attach to. Pretty remarkable. So ankyloglossia then is when there's an imbalance of the two roles, where stability is interfering with mobility. And so a frenulotomy might improve mobility, but it could undermine stability. So we need to be aware that if we release the lingual frenulum in kids with micrognathia or a cleft palate, it's going to alter their tongue position at rest and has the potential to actually worsen any pre-existing airway compromise. I want to be clear that releasing a tongue and allowing it to fall back will worsen obstructive sleep apnea, OSA, not improve it. And another history thing to think about is in kids with a severe cleft palate whose tongue would fall back and obstruct their airway, what did we do? We didn't have osteogenesis and the ability to put in and grow mandibles. So we tied their tongue up on top of their lip. So a tongue lip adhesion was an old treatment for airway obstruction, the exact opposite of a tongue release. So I read these through and I said, one difficulty I see is that this is a study of normal. She did not get to do any anatomic dissections on any specimen that had a feeding difficulty known. And we know that less than 50% of babies with an ankyloglossia by appearance have breastfeeding issues. So you don't always need to have a long, flexible frenulum in order to feed properly. And Dr. Kahiri has published work that said posterior tongue tie. Remember, that's a tough non-anatomic term. He had a randomized paper that showed there is a difference between babies before and after his release, and that he felt that there was a band or a pop under the mucosa that resulted in improved breastfeeding. So how do we put these two kinds of studies together? Is there a difference in a baby's anatomy that is having a tongue tie or a feeding issue? Is there a neurologic issue of how the tongue is moving? So because the abnormal development during embryology was not addressed, I went back and tried to look up the embryology of the tongue. And my work, I concluded that perhaps there's a persistence of the tuberculum impar to blame. So what is a tuberculum impar, you say? Well, a tuberculum impar is part of the original tongue development. It's in green in that 4-week embryo picture, and it's that little round ball. And you can see that through development, as it goes forward, it allows the two tongue muscles to come together, and it kind of recedes posteriorly back towards the voice box, back towards the epiglottis. So, if you propose that there's some band that's persistent, then maybe it is that band that instead of recessing backwards, it maintains the position between those muscles. That would be a persistence of an anatomic problem called the tuberculum impar. So maybe we've got an idea that could work, and maybe we just need to remember that all tongues are equal. Some are just more equal than others. So a frenulum is not a judgment. Doesn't mean it's good, doesn't mean it's bad. Sometimes that tongue functions easily, drawing milk out of the breast. Sometimes there's difficulty when the baby either pinches or has trouble swallowing. And there are some things beyond breastfeeding when a free tongue tip is needed, like to roll your Spanish R or to clean your teeth. But that doesn't mean that always babies need to have their tongue released. Turn it over to Shanna for the next slides.
So that's where I'm going to come in. I'm going to talk about kind of what happens in terms of breastfeeding with the mom and the baby. And so with the big push that moms are feeling pressured to breastfeed, and we want moms to breastfeed, what happens when there's difficulty? And that's where I recommend a thorough lactation evaluation. So a mom and baby dyad who have been addressed that are having breastfeeding difficulties, I have a couple of really quick fire things that I would want you to kind of ask or be looking for. And these can kind of help weed out which babies we think have a tongue tie that is causing difficulty that might need to be released, or that there is some other problem that's causing the difficulty in breastfeeding. So the very first question, and this should be number one in terms of is the tongue causing a problem, is does mom have nipple pain? So if a baby is diagnosed with a tongue tie but is breastfeeding fine and mom doesn't have nipple pain, in terms of lactation, that is a great sign that there does not need to be any sort of intervention for that tongue. But in terms of mom's nipple pain, I want you to find out about quality and characteristics. So how does she describe the pain? There are lots. What we know is that up to 90% of women who breastfeed will have nipple pain. It's usually within the first 18 days. By day 18 of that baby's life, nipple pain typically improves. It peaks around day 3, which is typically when most babies have left the hospital with their mother, and now mom is at home trying to breastfeed and is in terrible pain. So nipple pain, first question, what does it feel like? What we've tend to kind of have noticed that certain women will describe other characteristics of nipple pain like burning. Burning sometimes can actually indicate a yeast infection in the breast, not that it's coming from the baby's mouth. Deep, described as deep pain within the breast, that can indicate a bacterial infection that mom needs to get treated. So it's not necessarily that latch and fit and hold in terms of breastfeeding are causing the nipple pain. It could be something else. Where does mom feel it? So a lot of times moms will describe nipple pain at the top of their nipple, kind of all around. Those kind of are more indicative of how the nipple is being placed in the baby's mouth. And when during the feeding does mom feel her pain? So a baby that's staying latched best during mom's letdown might be not as aggressive as a feeder. And so when mom's letdown is happening, they are feeling most satisfied, and so their whole latch improves. Babies moms that feel pain during letdown and babies that come off after letdown or during letdown, those are moms that I get concerned may have an oversupply. And sometimes that milk is just coming out so fast that babies will actually bite down on mom's nipple to stop the flow so that they can compensate and swallow. So really kind of understanding when mom's having pain can really kind of help tease out what's going on. And then, did mom and baby have skin to skin or magic hour during birth? So that really comes into play in terms of our babies who have to go to the NICU or who had some trauma during birth or something that had them get whisked away. They usually don't get skin to skin or, even better, a magic hour. And research has shown that reintroducing skin to skin, or babies who get skin to skin, can have are much more likely to have increased length and more successful breastfeeding. And research has also shown that if you reintroduce a baby, say they had to get taken away and they come back and you allow mom to do skin to skin, we can actually reverse breastfeeding problems. And that research was done with babies all the way up to 16 weeks. So there's really good research that shows that that will help promote breastfeeding in between mom and baby. So did they get that magic hour or skin to skin? And then what does mom notice about the baby's mouth when she's breastfeeding? Do the lips stay on? Does she feel like the mouth looks pinched? What kind of motion is the jaw making? How does the cheek look? Those are all signs that maybe breastfeeding or the fit is not appropriate or could be adjusted. Some moms were like, I absolutely notice that the lip always gets tucked in, or his cheek is going in and out, and I can see that there's air. I will make a quick statement about that. We put a lot of emphasis on, do you hear a click during breastfeeding? And what we know is that clicking during breastfeeding doesn't indicate a tongue tie. Clicking during breastfeeding indicates poor fit and hold, and that something about the latch needs to be adjusted, but not necessarily that the tongue is the problem. And then, has the latch and the breastfeeding been assessed by a trained lactation professional? What research has also shown is that moms who have had an evaluation with a trained lactation professional feel an increased amount of confidence that then projects out into long-term breastfeeding. So these are just all things to kind of try to figure out, do we think that there's a problem with lactation and between the dyad anatomically, or is it something that we can adjust with the fit and hold? So when I'm doing a lactation assessment, I use a breastfeeding and a tongue tie assessment tool, and I wanted to introduce you guys to what's available. The Hazelbaker, the first one there, is the most validated. It's been around for years. It's a really thorough assessment of breastfeeding and tongue function of the baby, and it's been shown to be very accurate. The problem with introducing it into practice is that it takes a very long time. So a lot of people find that they don't use it because it takes so many steps. So over in England, they decided to try and create a quicker way to do an assessment to evaluate for tongue tie called the Bristol Tongue Assessment. And that one is much faster, and clinicians do like it more, but it hasn't been 100% validated. So we can't carry it over into everyday practice yet. There's another one that is gaining popularity, and that's called the Tabby, TABBY, and it's based on the Bristol, but what it has is pictures of tongues so that you can quickly look and identify what this tongue and anatomy looks like and where it falls, and it gives you a score. And I actually, after speaking with some pediatricians across the country recently, I've found that a lot of newborn nurseries are using the Tabby to make quick assessment just to decide if those babies need to have a tongue tie release or not. But again, it hasn't been 100% validated because it's based on the Bristol. So I just would caution people with using it. What I use is this. This is the modified Hazelbaker. And I previously had gotten this offline, and I had someone call it to my attention that they couldn't find it. So I did a really thorough like internet search to try to find it. And this exact one I couldn't find, but I can find ones that are very, very similar called if you put in modified Hazelbaker. And the reason that I like this is it's using the validated scoring, but it's quicker. So it's less questions and less time spent so that patients feel like I'm spending more time with them, but I'm getting all the points that are needed for the Hazelbaker. I actually, when I do a breastfeeding assessment, will give parents this once I've completed it. I now know it so well that I can do it while I'm watching a breastfeeding session, and then we go over it together as to what's happening with the tongue and with breastfeeding. If I see a breastfeeding mom and baby and we're having difficulty, I always have some really quick latch tips, and these are just important that anyone can kind of introduce that really seem to help and improve breastfeeding problems, specifically nipple pain, which is what I'm most likely trying to improve. And so the very first thing that always all lactation providers recommend is to have appropriate hold. We want to be holding baby the optimal way so that they can be doing all the things that they need to be doing. I prefer cross cradle because I think it gives, when we hold the baby in a cross cradle, it gives the baby the support of our arm and our hand is holding the head. So what you want is a baby needs to be able to move their head all the way back so that they can then open their mouth. And we want that, we call that a wide open gape. But research shows that if there is a hand at the back of the head, babies won't put their head back as far. So in cross cradle, we're able to support the neck so that their head can still move. So I prefer cross cradle. And then a lot of research is showing currently that you should not do anything to the breast. We want the breast to just be hanging naturally. But if there is a large breast that does need support, I recommend a U-hold. I think it's the least manipulation so that the breast and the nipple can naturally go into mom's mouth. And I always recommend to make sure to bring the baby to the breast. You don't want mom to feel like she has to be in some weird position to get her breast to her baby's mouth. That's going to already set her up to be uncomfortable. And then once we have the baby on and the baby's given us a really good open mouth gape, that's when we bring the baby to the breast with the least amount of manipulation. And when the baby is on, we want to look at that mouth, okay? The mouth should be, once the baby's on, we want to look at the angle of the mouth. So when she goes back, when that baby goes back for their gape, we want that opening to be at least 90 degrees. And then when she's on, we want the angle of the lips to be at least 90, but new research is showing 140 degrees, which is almost a straight line. So I really have parents look at that. Like when you're looking at your baby, is that angle super, super big? And then when they're watching their baby, what does the mouth and the jaw of the baby look like? And that was one of the things that I had previously mentioned on the other slide about what has mom noticed. Because what we want is, if it's a good latch, then the cheek should be very soft and round. We shouldn't see a break, like there shouldn't be an indent. And we want the jaw to be moving forward like a rocking chair. Babies' mouths who are going up and down like a piston, that means they don't have a deep latch. They're latched right on the front of the nipple, and that is going to cause nipple pain. And since we're talking about oral ties in general, I threw in these slides. Let's talk about lip tie, because that's the other hot button issue. One of the things I will tell you is that I see babies all the time sent to me because they are diagnosed with a lip tie because they have a frenulum. And what we know, and you'll hear that that frenulum's been classified as a grade 1 to 4. So all of that classification, that's all a dental classification, and all it says is that you have a labial frenulum. So moms will come in saying, oh my gosh, we have a type 4 lip tie. And basically, all that means is that their baby has a frenulum at their lip. It does not indicate severity. So I already tried to de-escalate by indicating every single mouth will fall on this classification system. We all need that, and that is completely anatomically normal. But if I do have concern about a lip tie and a baby who is breastfeeding, one of the first things that I always ask is, are you having pain? And where is it? These are very specific questions because anatomically, the lips help create the vacuum of breastfeeding. The tongue is used to move the nipple. So if a upper lip, not the bottom lip, if the upper lip vacuum is not secure or that lip doesn't have good mobility, that lip will curl in and moms will be feeling the upper gum bite into their nipple or their breast tissue because it's trying to hold on and create that seal that the lip wasn't able to. So moms of babies who have what would be considered a lip tie will have very linear pain on the upper portion of the breast where the upper lip would have been, and that lip goes in. So if the lip stays out or flange during breastfeeding, it's not tied. It would be a lip that would always be going in, and mom would have very specific pain. Sometimes you can actually even see a linear indent in mom's breast where that the upper gum was kind of grasping or biting down. But the other issue is if the lip flips, if you can take your finger and manually release it and it stays, again, I would not consider that restrictive. I would consider that a lip that's doing what it's supposed to, and you can you can release it with your finger and move it so that it creates the vacuum. The things that it's not, and these are also reasons that moms have come to me, is it's not a callus on the upper lip, it's not related to the lower lip, and it's not lips that are pale after breastfeeding. And this is the Google Trend slide for lip tie. And as you can see, it almost wasn't even discussed or heard of until at least 2010. And then since then has increased. The other thing I will say about this is lip tie is almost exclusively found in the United States. We have seen some more research coming from New Zealand and Australia, but most other countries, even like Western medicine countries, do not even consider lip tie something to talk about. And also, again, since we're talking about oral ties, I'm going to throw in a buccal tie because I have been seeing lots of babies referred to me because they were diagnosed with a buccal tie. Buccal tie is absolutely not a concern. That is normal. Those pictures there are babies who have been considered to have a buccal tie, and that is completely normal anatomy. If you did not have that tissue, there would be no structure for your cheek to stay on. I'm going to turn it back to Peggy.
Okay. So I hope that one of the things you get from this talk is that there are different people with different specialty information, and that we all need to work together in a multidisciplinary way to be able to make sure we are giving that mother-baby dyad their best chance of breastfeeding. So the pediatrician's going to be very important in making sure there aren't other medical issues going on. Congenital heart disease, any unborn errors of metabolism, craniofacial anomalies, things like that. And then that lactation specialist, listen to all those fine points that Shanna has on how to position, how to get things going. And she didn't even go into massage or supply and flow and those things that she also can address. And then a procedure list, whether that's an ENT doc like me or a dentist or a lactation specialist who's had training. those are going to be responsible for making sure that if a tongue is released, it's not going to cause more problems. So they need to be able to assess for retrognathia, clefts of the palate. Is the baby refluxing? How do you assess for that? How can you assess for any edema in the back of the airway? How about the neurology of the feeding? Is that baby just got a incoordination from being born too early? And what is the risk of airway obstruction? So for me, I will have that baby gently restrained. And for this talk, I just include this to let you know that it's something that's just as simple as isolating the frenulum, clipping that band, and then sweeping the floor, holding some pressure, and then afterwards feeding that baby for relief. The sugar in the breast milk or included in formula if they're drinking that or in a Sweeties is all that their little brain needs if they're having any pain. But I would say most of the time they settle pretty quickly. So next we wanted to go over why and what the American Academy of Otolaryngology says on ankyloglossia. So remember that takeoff and that extreme exponential growth happened in the 20 teens. And so by 2020, the Academy of Otolaryngology wanted to see if they could create a clinical practice guideline to help providers know what ankyloglossia is and how to treat it. And they found that there wasn't enough high quality evidence to generate a clinical practice guideline. So they did come up with a clinical consensus statement that used the Delphi survey method to come to that consensus. So multiple surveys are sent out to specialists, and then they're sent back and forth, and it identifies areas of consensus and areas of no consensus. And so the panel attained clear consensus that validates there is such a thing as anterior tongue tie, and it can affect breastfeeding. And it separated things into multiple tables. So in table one, the statements that reached consensus were that it is a condition, ankyloglossia is a condition of limited tongue mobility caused by a restrictive lingual frenulum. They also said that, yeah, practitioners are starting to describe it as anterior posterior, and that those who describe it as being anterior posterior usually mean anterior is the lingual frenulum extending to or near the tip of the tongue that's restricting upward mobility, but that in some communities, infants and children are being overdiagnosed. Remember, that's when the patient can actually have harm from the diagnosis. And that is leading to a significant number of children having unnecessary surgery on the lingual frenulum. Statements that also reached consensus were that buccal and ties are not something that should be released. That's why bulldogs have jowls. We really don't want babies running around with that. And that ankyloglossia does not cause sleep apnea, and in fact, release of a tongue could worsen it. Regarding breastfeeding and ankyloglossia, they said that breastfeeding difficulties are common in the newborn period, and that anterior ankyloglossia could be a potential contributor to infant feeding problems. The maternal pain and poor latch, as nicely described by Shanna, can be caused by ankyloglossia, but these symptoms, as described by Shanna, can also be present with other etiologies of breastfeeding difficulties. So that ankyloglossia in an infant should be evaluated with a careful history, including the lactation history and physical examination, including inspection and palpation. And that mother-infant breastfeeding dyad is really a vulnerable population, and so extra care is needed to ensure their support, education, counseling, and shared decision making. And from the Academy of Otolaryngology, that infant should be identified by a lactation consultant prior to undergoing a lingual frenulotomy. They further said that a lingual frenulotomy is generally safe and well tolerated. We don't recommend any topical anesthetic agents that can affect feeding down the line. Injected agents can cause and introduce bacteria under the surface of the tongue and cause infection, and that those sweeties have been shown to decrease the pain response in infants that undergo other procedures and could be given to infants who undergo frenotomy as needed, but that there was insufficient evidence to support claims that a laser was superior to other techniques of frenulotomy, and that after frenotomy, there is no evidence to support post-procedure care stretching, massaging, manual elevation of the tongue by the parents. Um, and I guess the completion of that sentence is just because that could lead to oral aversions. This is a little bit hard to see as I'm here, but the Academy basically summarized this multidisciplinary uh, um, evaluation, the need for that, and how to then decide, do you go to somebody to have a tongue? And then you can see that it's circular there. So even after a tongue is released, you need to go back to that primary medical home to make sure that all the other medical issues are being addressed. So they said that an infant with suspected symptomatic ankyloglossia be evaluated. They encourage pre and post feeding weights to look for either separate or concomitant causes, noting that there can be bottle preferences, prematurity, anatomic abnormalities, the retrognathia, mom's nipple differences. Maybe mama's had surgery on her breasts. That can cause a lot of breastfeeding problems. And then if ankyloglossia is found, to have a tongue release by a billable provider and to avoid costly non-evidence-based treatment. And for this, they're actually implying that you don't want to go to somebody who says, I'm going to do it in a way that I can't bill your insurance because it won't be covered. And that is really puts that mother-baby vulnerable dyad at risk. And that if after the assessment for ankyloglossia, it's found to not be a tongue tie, to send them back to have close follow-up with their primary for treatment of any other issues of breastfeeding trouble. So one of the things as we get near the end is that I think that we need to be aware that outside of a tongue release of the anterior frenulum for breastfeeding concerns, if a baby is brought into an emergency or urgent care and there is a laceration in the mouth on the frenulum, which will tear with enough trauma, that is considered a sign of physical abuse, and that it is a reason to look for other signs of serious physical abuse. And that I included a paper in the references that shows that recent research found that children under the age of 4 that have cheek, jaw, frenulum, torso bruising are at risk for having been physically abused and are at risk for future more serious abuse. So we want to not just go into that baby's mouth that can't say, no, thank you, it's not my tongue. It's not my mouth that's the problem. Please look elsewhere, just because they can't complain. So in conclusion, yeah, ankyloglossia can be symptomatic, but it's not the cause for every problem. But if it is, it can be released easily, and in that newborn or infant who's nursing every 3 hours really doesn't need a lot of extra work. And it's almost always successful in decreasing painful latching with the assistance of the lactation specialist to get that position and all right. And it can really be amazing. Where we really come into question is, what is a posterior tongue tie? It hasn't been universally defined. And remember, the posterior tongue is behind the top of the tongue, not in the front of the floor of the mouth. And the treatment for it definitely needs further study. Is it this tuberculum impar thing? Is it something else? Does it maybe occasionally happen, maybe not? So I would propose that we need to really see what the release of posterior tongue ties is doing, and to really then lead that to help us redefine and diagnose the risks, benefits, and alternatives to what tongue release really is. And I'm not sure on this one if that's going to, oh, well, great.
Let's try it.
Now you have a tongue, huh? You can use your whole tongue. That's a funny sound.
And there you can see that tongue clicking isn't always just about a tongue tie, because this is a baby that can now finally click her tongue after it's been released. Shanna, is there anything else that you wanted to say in conclusion?
Um, I wanted to go back and touch on what we were saying when you were talking about in anatomy, and I've had a lot of moms recently say that they really want to make sure that if the tongue is released, that they get a triangle band of where the in like afterwards, and that is a sign that it's been a good release. And again, as your slides pointed out, that is a completely arbitrary thing, and in fact we don't necessarily need a triangle shaped wound afterwards.
Yeah, or some people describe it as a diamond as well, so kind of a double triangle. All right, well, we would welcome any questions and certainly appreciate your attention during this webinar. Thanks very much.